few announcements before we start. So our next grand rounds will be February 18th. Our speaker will be Dr. Andrea Stand, one of our geriatric fellows, and she's going to be talking about prostate cancer. Our next journal club is February 11th, and our presenters are Doctors Carrie Hornay and Gretchen Oros. So please join us for that. Other announcements, there is a division meeting via Zoom following grand rounds this morning, starting at 8:30. So please log on to that if you're attending. You will receive an email later today with a link to today's presentation and copy of the slides. There'll also be a link to an online evaluation. So if you could please take a moment to fill that out, that would be very helpful. Please submit any questions during the presentation through the chat or the Q&A box, and we'll have time to go through those at the end of Dr. Gause's presentation. So I'm pleased to introduce our speaker today, Dr. Megan Gause. Dr. Gause completed her undergraduate work at the University of Oklahoma with a major in health and exercise science and a minor in zoology. She graduated from medical school in South Carolina and completed a family medicine residency at UC Health Poudre Valley Hospital in Fort Collins. And then we were fortunate enough to bring her down here to do her geriatrics fellowship. And she's going to talk to us today about depression in the elderly. So take it away, Dr. Gause.
Thank you, Dr. Eldredge. So today I'm talking about depression in the elderly, a review of the prevalence, treatment, and recent literature. I chose this topic for a few reasons. I see it very commonly as both a geriatric fellow and also during my family medicine residency. Also with COVID, there has been an anecdotal increase in depression in the elderly and in the general population. And finally, one day in clinic a month or two ago, every single patient I saw had concerns for depression, and they opted for different treatments. So it seemed like a good topic to discuss. So the learning objectives, we're going to define depression and understand how it's diagnosed, recognize depression in the elderly as a public health problem, recognize the correlation between depression and other medical conditions that are treated in the primary care setting, understand the increased risk for depression in relation to isolation during this global pandemic, understand treatment options for depression, both pharmacologic and non-pharmacologic, and some current research that I found on this topic. And then also future areas of research for late life depression and treatment modalities we'll bring up a little bit towards the end of the topic. So to define major depressive disorder, it's greater than or equal to 5 of the following symptoms that are located on the next slide, present for at least a span of 2 weeks and are a change from prior functioning. At least one of the symptoms is either depressed mood or a loss of interest or pleasure. The symptoms must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The episode cannot be attributable to the direct physiological effects of a substance or to another medical condition. I think the attributable to another medical condition is very important to note. There are a lot of medical conditions that can, at least in part, mimic depression. These include, but are not limited to, bipolar disorder type 1 and type 2, schizoaffective disorder, schizophrenia, alcohol use disorder, or other mental disorders. That could honestly be a complete talk on its own. So for today, I'm only focusing on major depressive disorder and not how to rule out these other disorders. So the GDS, or the Geriatric Depression Scale, is a well-validated tool for assessing depression in elderly patients. It was developed in 1982 by Yesevaj et al. And updated in 1986 to the short form. The GDS, Geriatric Depression Scale short form, or the GDS-SF, is 15 questions. It's more patient-friendly than the 30-question GDS and takes a lot less time for these patients to complete. That's helpful in a very busy clinic setting when The provider only has a set amount of time with the patient. So in my experience in the clinics I've worked at, the GDS-15 is used much more commonly than the GDS-30. Here is a list of symptoms that are utilized to diagnose major depressive disorder. On my screen, at least, they're a little bit hard to read. They include a depressed mood for a majority of the day, decreased interest or pleasure, change in appetite or weight that does not have another underlying medical cause, changes in sleep, feeling restless, or alternatively having psychomotor retardation, fatigue, feeling worthless or having guilt nearly every day, trouble concentrating, or thoughts of dying, or feelings that you would be better off dead. Finally, and perhaps most importantly, would be increased suicidal ideation or a plan for suicide. I found a recent meta-analysis that was completed in 2020, reviewing the different available geriatric depression scales for diagnostic accuracy. In this meta-analysis, there were a total of 53 studies with 17,018 participants that were included in the review. The pooled sensitivity and specificity of the GDS-30, the Geriatric Depression Scale 30, was 82% and 76% respectively. The GDS-15 had a pooled sensitivity and specificity of 86% and 79% respectively. The GDS-10 had a pooled sensitivity and specificity of 87% and 75% respectively. And this study found that the GDS-4 had a sensitivity of 74% with a specificity of 71%. So in conclusion, the meta-analysis found that all the forms of the GDS are highly useful for detecting depression among elderly patients, both with high sensitivity and specificity. The diagnostic performance, however, was much better for medium length forms of the geriatric depression scale, such as the GDS-15 and 10, when compared to the GDS-30. So the 15 is actually slightly more effective in diagnosing, or has a higher sensitivity and specificity compared to the GDS-15. And then the GDS-4 was the least sensitive and specific. These are the questions on the GDS-15. The bolded yes, no response that you can see is the answer that counts for points towards the total score. There are 5 no responses that result in 1 point each, and 10 yes responses that result in 1 point each. A score of 0 to 4 is considered normal. A score of 5 to 8 indicates mild depression. A score of 9 to 11 indicates moderate depression. And a score of 12 to 15 indicates severe depression. The GDS-30 has a different scoring system, as does the GDS-10. Those values are specifically for the GDS-15. The PHQ-2 is a quick depression screen used in the clinical setting. It consists of 2 questions. Over the past 2 weeks, how often have you been bothered by any of the following symptoms or problems? 1, little interest or pleasure in doing things, or 2, feeling down, depressed, or hopeless. In my experience, clinics that use the PHQ-2 as a depression screen start with the PHQ-2 as a quick screener. And then if the PHQ-2 score adds up to greater than 3 points based on the patient's answers, then the patient will be prompted to complete the PHQ-9. The PHQ-9 score greater than 10 has 88% specificity and 88% sensitivity for major depressive disorder. So there's a book called the DSM-5, which many of you may have heard of, the Diagnostics and Statistical Manual of Mental Disorders, version 5. It's the most recent tool for helping clinicians diagnose mental health disorders. Version 5 came out in 2013, and the bereavement exclusion criteria was removed from the 5th version of the DSM for the diagnosis of major depressive disorder. The bereavement exclusion criteria in DSM-4 stated that grief from loss of a loved one or other trauma is normal and does not give someone a diagnosis of major depressive disorder. The bereavement exclusion was eliminated from the DSM-5 for 2 main reasons. 1, there have never been any adequately controlled clinical studies showing that major depressive syndromes following bereavement differ in nature, course, or outcome from depression of equal severity in any other context, or from major depressive disorder appearing, quote, out of the blue. And 2, major depression is a potentially lethal disorder with an overall suicide rate of about 4%. Critics of the removal of the bereavement exclusion criteria state that removing this criteria will medicalize ordinary grief and perhaps encourage overprescription of antidepressants in the population. So the DSM-5, in summary, states that a response to any significant loss can resemble a depressive episode, and it might be an appropriate response, but providers should still consider major depressive disorder as a diagnosis for these patients. I think clinicians need to account for the specific episode that the patient is experiencing, the patient's level of grief, their past medical and family history, as well as the patient's baseline prior to the grief episode, if you're fortunate enough to know the patient's baseline. Depression in the geriatric population is obviously what we're talking about today. It's both a common and a serious health concern. As we will soon see, it can exacerbate other medical conditions, impair functioning, it can utilize excessive healthcare resources, and cause increased mortality, including suicide. Within the general elderly population, male African Americans and male Hispanics are at greatest risk. And as my physician and NP/PA provider colleagues or any other patient-facing clinicians can attest, greater than 80% of late life depression is treated in the primary care setting. Depression is not a normal part of aging, in spite of what our patients might tell us. Also, memory, but that's another topic. Memory loss is not a normal part of aging. Of course, grief and sadness can be normal responses to certain life events, such as loss of a spouse or loved one, loss of independence, which many of our patients experience as they retire from driving or are moved to independent assisted living and skilled nursing facilities, and a decreased ability for patients to complete activities of daily living, such as bathing, dressing, or feeding. The rates of depression vary widely in studies that I found and range from 2% to 10% in community dwelling older adults. Hospitalized geriatric patients have rates of depression as high as 30%, and those with a history of a heart attack, cancer, or stroke have rates of depression as high as 40%. The cost of depression to the United States healthcare system is estimated to be about $210 billion annually. And the USPSTF, or the United States Preventive Services Task Force, recommends screening all adults, including elderly adults, for depression. I put their formal statement here on a piece of paper. I'll read it to you guys. The USPSTF concludes with at least moderate certainty that there is a moderate net benefit to screening for depression in adults, including older adults, who receive care in clinical practices that have adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up after screening. And that is a level B recommendation from the USPSTF. This chart is the prevalence of depressive disorders in various patient populations. So the rates of depression can vary widely, as you can see on this graph, ranging from 2% in community dwelling older adults versus 6% in the general adult population, as high as 47% in patients who have experienced a stroke. Patients who have cancer that are inpatient are 42%, and having had a heart attack, you have a 45% risk of having depression. To me, as a provider, 2% does seem like a low estimate of what percentage of community dwelling elderly patients that I have with a diagnosis of depression. That's just what this chart showed. There are some risk factors that put you at a higher chance of having late life depression. They are female sex, social isolation, which we'll talk about, being widowed, divorced, or separated, having a lower socioeconomic status, having concomitant comorbid general medical conditions. If the patient has uncontrolled pain, they're at increased risk for late life depression. If they experience insomnia, or if they have functional or cognitive impairment, which many of our elderly patients have or are at risk of having in the next couple of years. I found a prospective cohort analysis titled Gender, Depression, and 1-Year Prognosis After Myocardial Infarction. There were 896 patients enrolled, and they used the BDI, or the Beck Depression Index, to evaluate the patient's level of depression. A score of greater than 10 was clinically significant depression. This study found that previously or newly diagnosed depression in the hospital after a heart attack is a significant predictor of 1-year cardiac mortality, regardless of gender. It is an old study from 1999, but it still shows us the importance of recognizing and treating depression for overall benefit on mortality in our patients. Depression and suicide. As of 2010, and we don't have the 2020 census results yet, so I would guess probably higher now, people over the age of 65 make up 13% of the population, but they account for 24% of completed suicides. They are much less likely to attempt suicide than the younger population, but are more successful at completion of suicide. 28.9 per 100,000 elderly men commit suicide annually, and within that group, the highest rate of completion are men over the age of 85, with a rate of 55 per 100,000. Most geriatric patients that complete suicide were actually in their first depressive episode when they commit suicide, and they had seen their primary care physician or a specialty physician within the last month of their life. Depression and dementia. This is a 2013 meta-analysis that I found titled Late Life Depression and Risk of Vascular Dementia and Alzheimer's Disease, a systematic review and meta-analysis of community-based cohort studies. It was published in the British Journal of Psychiatry. It showed that late life depression is associated with an increased risk for all-cause dementia, vascular dementia, and Alzheimer's disease. In my personal search of recent research on this topic, I found that there was actually a paucity of high-quality data on depression and other medical comorbidities, and I would be really interested to see more research on the correlation between depression and dementia, especially in geriatrics. I did find one study that showed a correlation between the severity of depression in a patient and their length of dementia-free survival. It was published in the Journal of Geriatric Psychiatry and Neurology in July of 2020. It's titled Depressive Symptoms Predict Incident Dementia in a Community Sample of Older Adults, Results from the Einstein Aging Study. It was a longitudinal cohort study that used the GDS-15 to monitor older community dwelling adults. The primary outcome was dementia diagnosis based on DSM-4 criteria. In this graph that I have here, you can see that patients with severe depressive symptoms, indicated by the red line, had a significantly lower incidence of dementia-free survival compared to no or mild symptoms or moderate depression, as indicated by the green and the blue lines. Among all participants, after controlling for demographic variables and medical comorbidities, a 1-point increase in GDS was associated with a higher incidence of dementia, with a p-value of 0.007. After 3 years of follow-up, depressive symptoms were not significantly associated with dementia incidence, with a p-value of 0.07. But after more than 3 years, the GDS score was a significant predictor of incident dementia, with a p-value of 0.028. Among participants, 132 individuals developed dementia over an average of 4.5 years of follow-up. Participants had an average age of 78.3 at baseline, and 62% were women. After up to 3 years of follow-up, depressive symptoms were not significantly associated with dementia incidence, as we mentioned. In conclusion, the results suggest that after 3 years of follow-up, the GDS score was a significant predictor of incident dementia. Isolation is a risk factor for depression, as we talked about earlier. And depression in the general population, as well as in the geriatric population, is anecdotally becoming more prevalent during the COVID-19 pandemic. A March 2020 review of prior evidence surrounding isolation during pandemics, published in The Lancet, noted that stressors during quarantine included duration of isolation, frustration about having to isolate, boredom, inadequate supplies during quarantine, and inadequate information. This study also found that ways to mitigate stressors included keeping quarantine as short as possible, giving as much information as is known to the disease, providing supplies to people in need, improving avenues of communication, including Zoom, telephone, and window visits. So this is not to suggest that quarantine should not be utilized, because the psychological effects of not using quarantine and allowing the disease to spread probably are worse. I did, unsurprisingly and unfortunately, find some ethnic disparities in the treatment of late life depression. This study that I have a copy of one of the graphs here, published in JAMA in March of 2020, showed that the racial and ethnic disparities that exist between incidence of late life depression and overall symptom burden, as well as percentage of those getting treated. It's titled Association of Race and Ethnicity with Late Life Depression Severity, Symptom Burden, and Care. The participants were community dwelling elderly patients from a previous study that was looking at vitamin D and omega-3 use in cancer and cardiovascular disease prevention. There were 25,503 participants with adequate depression data and a mean age of 67.1 years, including 12,888 women, about 18,000 non-Hispanic white participants, 5,000 Black participants, 1,000 Hispanic participants, 380 Asian participants, and 1,300 participants who were categorized in the other, multiple, or unspecified race group. After adjustment for sociodemographic, lifestyle, and health confounders, Black participants had a 10% higher severity level of PHQ-8 or depression scores compared with non-Hispanic white participants. That p-value was 0.001. Hispanic participants had a 23% higher level of PHQ-8 scores compared with non-Hispanic white participants, with a p-value of 0.001. And participants in the other, multiple, or unspecified group had a 14% higher severity level of depression scores compared with non-Hispanic white participants, with a p-value of 0.007. Compared with non-Hispanic white participants, people belonging to the minority groups had 1.5 to 2-fold significantly higher fully adjusted odds of anhedonia, sadness, and psychomotor symptoms. Multivariable adjusted odds of sleep problems and guilt appeared higher among Hispanic versus non-Hispanic white participants. In spite of these increased odds of depression and depressive symptoms in Black and Hispanic participants, this graph here shows us that Black participants were significantly less likely to be prescribed antidepressants compared to non-Hispanic white participants across all different models of analysis. This to me shows that there are perhaps systemic changes in our medical system that need to take place in order to improve medical care for our Black and Hispanic patients. For the treatment of late life depression, it could be its own 1-hour lecture, but I'll briefly go over some of the most commonly used treatments today, as well as newer data on treatment for refractory or medication-resistant depression in the elderly. Treatment includes and depends on addressing comorbid conditions, psychotherapy, titrating medications to efficacy for individual patients, and close follow-up, as well as continuity with the same provider if possible. Importantly, you want to assess suicidality. Ask the patient about an intent to harm or kill themselves. I always use both the words kill and harm. I remember in residency, one of my co-residence patients said to them, quote, "I do not want to hurt myself, I want to kill myself." So it's very important that you're using the appropriate word so that the patient is heard. Also ask about a plan for suicidality, and of course, ask about any weapons in the home, including guns. Finally, you want to ask whether or not the guns are loaded, where the guns are stored, are they locked away, and if so, who has access to the keys. The clinician should address any malnutrition or insomnia. Side effects of depression in elderly patients include, but aren't limited to, decreased appetite and sleeping difficulties. It's important to acknowledge these and discuss possible treatment options with patients. As always, with our geriatric population, medications can cause a lot of problems. So the clinician should do a medication reconciliation. Are they on any medications that could be sedating and possibly affecting their mood or alertness? This could include, but isn't limited to, benzodiazepines, opioids, gabapentin, and so on. The clinician should also ask about substance use. Are they using alcohol, marijuana, any street drugs, or prescription drugs that are not prescribed to that patient? As far as non-pharmacologic therapy is concerned, these are some resources that the university and the VA, both places that I work at, have on hand for patients who do not wish to pursue pharmacologic treatment. Frequently used techniques by the psychologists and the geropsychologists who I briefly spoke to include cognitive behavioral therapy and behavioral activation. Cognitive behavioral therapy, or CBT, is based on a model that states that the way we perceive thoughts influences our emotions. The therapy identifies distressing thoughts and helps to evaluate how realistic they are. For example, this is a patient saying, "My son canceled his lunch plans with me today. He must hate me." The goal of CBT is to change this type of thinking to a more balanced perspective and say something instead, such as, "My son canceled his lunch plans with me today. He must be busy and will certainly reschedule for a later date." Behavioral activation is designed to address avoidance that depression causes. An example of this one is, if you're feeling down or depressed and you decide to stay in bed all day, you're going to feel worse. Behavioral activation helps people find activities that will be pleasant to them, with the goal to increase those activities in the patient's daily life in order to lessen depressive symptoms. Both the university and the VA also have a geropsychiatrist that patients can be referred to for help with medication treatment of depression if the clinician is no longer able to handle it on their own, or if they have exhausted all of their resources. We talked a little bit about the counseling already and what techniques are employed. And then, as we will see shortly, exercise of any type has been proven to reduce depression and depressive symptoms in patients of all ages. A 2020 meta-analysis in the Journal of Clinical Psychiatry found that physical exercise has a moderate effect of lowering late-life depressive symptoms. One downfall of this meta-analysis that the authors did point out is that there was heterogeneity between the studies, likely due to a difference in methodology. Further research is needed, but so far is promising towards showing that late-life depression can be reduced by exercise, the same as in the younger population. However, a uniform exercise intervention is not recommended because patients enjoy different types of exercise. So exercise should be tailored to the individual's needs. Okay, moving on to the medication side of this discussion. Only about 50% of patients respond to initial antidepressant treatment that has a strength of evidence of A. An additional 33% respond when the agent is switched, another agent is added, or psychotherapy is started. Most commonly prescribed medications for late life depression include selective serotonin reuptake inhibitors, also known as SSRIs, such as citalopram, Celexa, escitalopram, which is Lexapro, sertraline, which is Zoloft, fluoxetine, which is Prozac. The medications in the SSRI class of drugs prevents serotonin from being taken back up into the presynaptic neuron, which increases the amount of serotonin present in the synapse, thus magnifying the effects of serotonin in the brain. Potential side effects of SSRIs that are of special concern for our elderly population include Parkinsonism, akathisia, anorexia, sinus bradycardia, and hyponatremia or low sodium. A dose-related increased risk for fragility fractures was reported also in one observational study. Fragility fractures are fractures resulting from minimal trauma, so suggesting weak, brittle bones or osteoporosis. If those medications fail, there are some second-line options available. Serotonin norepinephrine reuptake inhibitors, otherwise known as SNRIs, such as duloxetine, which is Cymbalta, and venlafaxine, which is Effexor, are good alternatives to patients who don't respond to or tolerate SSRI medications. They also have evidence to support using these in patients with depression and chronic pain with good efficacy. Both of these medications, duloxetine and venlafaxine, can cause a dose-dependent increase in diastolic hypertension. Bupropion, also known as Wellbutrin, which is a norepinephrine and dopamine reuptake inhibitor, is generally considered an activating agent, so it might be useful in patients who complain of lethargy, daytime sedation, or fatigue. Bupropion is contraindicated in patients with seizure disorders, concurrent use of benzodiazepines or other CNS depressants, alcohol detoxification, or prior or current diagnosis of bulimia nervosa. Dose-dependent diastolic hypertension is also a concern with this medication. Mirtazapine is a noradrenergic and serotonergic antidepressant. It's also used as a second-line agent. It's useful for patients with insomnia, agitation or restlessness, and anorexia or weight loss. It may also be useful in patients with Parkinsonism, essential tremor, or nausea from chemotherapy, and is available as a rapidly dissolving sol tab preparation. This is not the best phone screenshot of a chart in the Geriatric Review Syllabus version 10 that was published in 2019. It's a copy of the antidepressants that are recommended for late life depression in the Geriatric Review Syllabus. On top of the list, as you can see, is SSRIs, which we talked about, with a list of some common precautions. Next is SNRIs, and then TCAs, or tricyclic antidepressants. I think caution should be used in prescribing TCAs to elderly patients due to their anticholinergic side effects. TCAs include nortriptyline, but they're older drugs and they're not shown to be more efficacious than SSRIs or SNRIs. And in general, for me, at least in my practice, I avoid TCAs due to their lack of superiority and their side effect profile in our elderly patients. Moving on to refractory depression. There is some newer research and exciting research on electroconvulsive therapy for refractory depression. ECT, or electroconvulsive therapy, induces seizures in the brain under general anesthesia. Human and animal studies show that ECT increases release of monoamine neurotransmitters, particularly dopamine, serotonin, and norepinephrine. ECT also enhances monoamine transmission by desensitizing presynaptic adrenergic autoreceptors. So there's no question about the efficacy and safety of ECT, which is practiced widely and in the United States and the rest of the world. However, it does remain controversial and stigmatized because of misinformation and outmoded perceptions about how the treatment is performed. There was a study that I found that was from 2016 called the Prolonging Remission in Depressed Elderly, or the PRIDE study. It was a two-phase multi-site study. Phase 1 was an acute course of right unilateral ultra-brief pulse ECT combined with open-label venlafaxine, and it was performed at 7 academic medical centers. In phase 2, which was reported separately, patients who had remitted were randomly assigned to receive pharmacotherapy, which was venlafaxine plus lithium, or pharmacotherapy plus continuation ECT. In phase 1, depressed patients received high-dose ECT at 6 times the seizure threshold, 3 times per week. Venlafaxine was started during the first week of treatment and continued throughout the study. The primary outcome measure was remission, assessed with the 24-item Hamilton Depression Rating Scale, or the HAM-D, which we didn't talk about today. It was administered 3 times per week for the patients. Secondary outcome measures were post-ECT reorientation and safety. Paired t-tests were used to estimate and evaluate the significance of change from baseline in the HAM-D scores. They concluded in the PRIDE study that right unilateral ultra-brief pulse ECT combined with venlafaxine, which is Effexor, is a rapidly acting and highly effective treatment option for depressed geriatric patients with excellent safety and tolerability. These data add to the evidence base supporting the efficacy of ECT to treat severe depression in elderly patients. I did do a quick Google search last night of ECT in Denver, and I found a lot of hospitals in the area that offer ECT for severe depression resistant to medication use. UC Health actually opened its first refractory depression clinic in October of 2020. It's located at Longs Peak Hospital, which is in Longmont, and you have to be referred by a primary care provider or a behavioral health specialist. You can also call their number. I didn't because it was like 8 p.m., but that's helpful to know for our patients. And then finally, there is some ongoing research looking at intranasal ketamine for the treatment of depression, specifically comparing it to ECT. There's not a lot of newer research on these new non-pharmacologic interventions, but research in the general adult population is ongoing, and there are published case studies of older adults handling these treatments well, including the ketamine and the ECT. So in conclusion, just be on the lookout for future research on treatment-resistant late-life depression, including ECT, transcranial magnetic stimulation, which we did not discuss today, and intranasal ketamine. So that's it. Thank you, guys. I opened up the chat, and Dr. Stan says we should transition to the GDS-10 in clinic to save time and increase sensitivity. That makes sense. I agree. And then Dr. Schwartz says, is the rate of depression cumulative in patients with multiple diagnoses? It's a really good question, and I don't know the answer to it, but I would imagine yes. That the more multimorbidity that you have, the more likely you are to have depression just with symptom burden and medication burden. You're muted, Dr. Hilder.
Thanks, Megan. That was a great talk. A couple questions in the Q&A box. So one is regarding the meta-analysis on scales to diagnose depression. What was the gold standard used to calculate the sensitivities and specificities among the articles?
That's a really good question, Dr. Matlock. I don't know. I don't know the answer. I can pull the article up and look it up for you though later.
And then the other question from Dr. Wallace is whether you read anything about pharmacogenetic testing to help guide choice of medication treatment.
I did not.
Okay. Are there any other questions or comments for Dr. Gause? Okay. Well, yeah, just another comment on that follow-up from Dr. Matlock, that you saw how difficult to interpret sensitivities and specificities unless they're all comparing to the same gold standard.
Yep.
All right, well, I don't see any other questions coming in. So again, thank you for a great presentation. Thanks to everyone for joining in, and please watch your inbox for a link to the presentation as well as the online evaluation. And we'll go ahead and end early and give people a few minutes to get ready for the division meeting. Thanks, everyone.